Everyone. Oh, hurry on. Good morning, everyone. Thank you so much
Hey.
for joining us today on the Medicare Cafe. I'm Sadie. You get to see my face again, and then I get to be behind the camera, and you guys can get rid of me here starting next week. But Chalen, you're back. Welcome.
I'm back. I'm here.
How long has it been since you? A month or so since you've been on?
Yeah, something like that.
Yeah,
3
you've been
weeks,
traveling.
maybe. I'm all over the place.
Where have you been?
Colorado. Let's see, we're Dallas. All over the
Nice.
place.
All over the place.
Yeah. Headed
Cool.
to DC next week and then Miami.
Nice. Yeah, all over the place.
June's a busy month.
Yes, June
Busy
June
month.
is a busy month for important people like you who are needed all over the place. You were in Colorado for NABIP stuff. How'd that go?
It was really good. The Colorado NABIP folks put on a great event. So we flew into Denver and then drove over to Vail, which is a beautiful drive.
Yes.
And got to spend a little bit of time with the folks out there. I think they had about 180 people at the event.
Nice.
So good turnout, a lot of great speakers. I was able to share some ideas on how to get past being stuck in your business and no matter where you are in that business, and was really well received. And we got to hear from some other great speakers on regulatory updates and PBMs and how those contracts work, all sorts of great stuff.
Cool. Love it.
Yeah, it's a good trip.
Yeah. Okay, guys, today we're going to have probably a little bit shorter of an episode, but today we're going to talk about sort of the elephant, at least in our room.
Absolutely.
We are going to be talking a little bit about some of the changes that have happened recently with commissions and UHC, and just talk about that in general. Talk about how that affects the industry, what it means whenever, because, they're not like the first company to ever
Absolutely
take a plan and go non-commissionable, and what that means from like the carrier side and all that sorts of stuff. So, Chalen, let's talk. Oh, actually, I haven't even done my whole spiel. Go ahead and text me. I have my phone here. Feel free to throw it in the live chat. Any questions, comments, concerns, threats, promises that you have about this. Let's talk about it. But yeah, can you kind of explain a little bit like what's going on with UHC and the non-commissioned stuff?
Yeah, absolutely. So as you all probably saw yesterday, got some notices, some contract addendums from United Healthcare, and they are taking a number of predominantly PPO plans and making them non-commissionable and pulling them off enrollment platforms starting 7/1. So that's coming up pretty quick in the next couple weeks, and it's a lot of plans. It is a pretty big list compared to some of the other carriers, some of the other things we've seen over the past year. But I don't think it's really that out of character for what's going on in the market either.
Totally, yeah. We just like haven't really, I feel like, been seeing it for PPO plans. Like it's like starting to kind of like filter in from, well, we've been hearing more about like obviously PDP plans, but now that it's like kind of filtering into the actual like MA plans, it feels a little scary. And then also it feels a little scary to hear like such a big name like doing it and being like, okay, so if UHC is doing it, what does this mean? What does this say about our industry and what this AEP is going to look like and stuff like that? So could you talk a little bit about Hallie? Sorry, our intern's over here. She's in the back and she's coughing. I'm making her, she turned bright red when I said that. But yeah, can you talk a little bit about what does it mean whenever carriers are starting to say, hey, we're going non-commissionable with these plans? What does that mean? What is that reflecting in the industry from like the carrier's perspective? What is that?
Yeah, so I think, it's no secret, no surprise to anyone that carriers are under a lot of pressure right now, financially, regulatory wise, in the courts, wherever. Pressure is the theme this year.
Sure.
So I think they're really taking a hard look at their block of business, their bottom line, their plan selections, and seeing what can we invest in and what do we maybe need to step back from. And that's really all this is. It's signaling. It's saying, hey, these plans, these PPO plans, which, by the way, it's only around 15% of all UHC PPO plans that they have. And PPO plans are only about 24% of UHC's enrollment in MA.
Oh, okay.
So
that's
it's really a tiny chunk of it's really a tiny chunk of all of the UHC plans that are available on the market.
But certain markets.
Certain markets definitely more affected than others.
Sure.
Obviously, the list is out there. You should have gotten an email. If you don't have it and you need a copy, of course, you can reach out to us. Brad popped in a great question, non-commissionable for new biz only or renewals. Also, it is non-commissionable for new business only, Brad, starting 7/1 signature dates and later. Good question. But yeah, it's really just signaling. They're saying, hey, we're looking at our business. We're seeing plans that are not performing well. And it could be for any number of reasons. It could be high medical loss ratios. It could be low membership. It could be anticipating lower star ratings. Something is telling the carrier, whether it's UHC or any of the other carriers that have done this in the past, something is telling that carrier, we can't really invest in this plan anymore.
Yeah.
We don't think we're going to have the money to invest in it because our reimbursements are going to go down, or we don't think we're going to get a better star rating, so we won't have that extra money to invest. And they also are kind of behind the 8 ball on cutting benefits. So even if a carrier says, hey, we want to keep this plan on the market, but we're going to have to cut benefits, they've got limitations on how much they can cut those benefits every year under the total beneficiary cost threshold that CMS sets every year.
Yeah.
So if a carrier is looking at a plan and says, hey, we need to cut benefits, but we really don't think we can cut them enough to get this back to profitability in 1 year, it's going to take 2 years, it's going to take 3 years, going non-commissionable is a great way to reduce that enrollment into that plan and potentially stop it altogether without having to terminate the plan. You got to realize that, Medicare Advantage carriers don't have the option like a Med Sup carrier does to just close a block of business.
Right.
So, for example, Mutual of Omaha, you pick any big carrier on the market in the Med Sup space, pretty common that they will close a block of business, say we're not taking new members, and they do that as a protectionary move. They want to try to keep that block the way it is, maybe let some folks fall off of it over time, and then open up a new block to kind of start over. MA plans don't have that option. Going non-commissionable and pulling it off enrollment platforms is the closest thing they have, and that's really how you should treat it. They're telling you, hey, we don't think it's a good idea to sell this plan anymore. I know there's a lot of agents out there that are really frustrated saying, we don't want to work for free. We don't want to enroll people in plans that don't pay us money. The carrier's not asking you to. Like, the carrier is very much asking you not to do that. Right. To be clear. So I think that's one of the big takeaways is, this is pretty clear signaling that there's not going to be a ton of investment in these plans going forward, that there's not going to be a ton of upside. Anyone you put in that plan between now and the end of the year, you're very likely going to have to move for next year. Just because the benefits aren't going to be what they are today. So take it for the signaling that it is, for sure, and just come up with a plan to deal with that. I know Michael just popped in that half of Iowa lost their $0 HMO plan. There were absolutely some HMOs, some HMO POS, even a couple DSNPs on that list. Definitely very upsetting. But again, it all depends on what that market looks like for them. I know up in Iowa, Michael, you're probably aware, one of the fastest growing rates of cancer diagnosis in the country in Iowa right now.
Really?
Absolutely. It is climbing the charts.
Like specific cancers or?
Not necessarily specific cancers, just like I don't know enough to say which specific cancers, but it's not just like all cancers.
Sure. I didn't know if it was like colon
cancer. I don't think it's like
or
one
if it's like
cancer, but it's not like all cancers across the board.
Sure.
But so Iowa is just climbing the charts. And, we know for a fact that cancer and musculoskeletal disorders are the top 2 causes of cost, especially in that like 65 to 69 range of beneficiaries. We see that on the Med Sup side. It happens also on the Medicare Advantage side.
Yeah. Interesting. So do you think that this is something that we can expect from to continue to happen with different carriers across different markets?
Yeah, I think so. I think carriers are really having to take a hard look at their business right now and really look at where do we want to focus, where do we want to prioritize. I think, maybe not this year, maybe not next year, maybe not soon, maybe not ever, depending on how things go. But the days of one carrier having 6 plans in a market are not going to be around much longer.
Right.
Carriers are really going to have to streamline their product offerings and focus on profitability. That's why we saw such big growth in C-SNP plans last year. Those are an area where carriers can still have a lot of profitability, a lot of effectiveness.
Yeah.
And then looking at, we've got markets like Ohio is a great example. Ohio consistently has some of the most diverse plan markets in the country. There were 4 counties in Ohio this past year that had over 70 plan options in that county. And options are great, but that's a little absurd.
Yeah.
It really is.
I don't want to give them too many options.
Yeah.
It's like kids, you want this or do you want this?
Yeah. So I'm a big believer that people need to have choices, but I do think, if you're a carrier and you're trying to offer 5 or 6 plans in a county, you're going to struggle, especially the further away you get from those metro areas. That I absolutely can see a world where we have 1 or 2 plan options from each carrier in non-major metro counties, because they have to have that minimum threshold of membership for it to even make sense.
Yeah.
I think a lot of carriers are also looking down the road at some of the other things that have popped up in proposals over the years, some changes that have been, floated around in back rooms and things like that. Whether it's changing how many and which types of plans can share a contract ID, whether it's changes to star ratings, floating this value-based care model and trying to promote that in a bigger way. I think there's a lot of changes that are yet to be seen in the Medicare world that could also impact, again, just how many plans a carrier wants to offer in a given market.
Yeah, that makes sense. Let's see. Number 2 in the nation for new cancer. And Will says Iowa has the 5th highest melanoma and 9th highest breast cancer rates. And prostate cancer is rising faster in Iowa than any other state.
Yeah.
Interesting. So that means that
Number 1 is Kentucky, by the way, for cancer incidence.
Because of the mines.
Yeah, mines, lack of access to quality health care, socioeconomic issues. There's a lot of factors that go into it.
Yeah, we could talk about cancer insurance all day long. We won't because we have, but
we've been there, done that.
Yeah, we've been there, done that. So definitely
right cancer
something
insurance.
to look into. Right
That's
cancer insurance,
plug.
honestly, at this point, right cancer insurance. This is kind of top of mind because Ben and I had just last week done a webinar over D-SNP plans.
Yeah.
And how much the carriers are like, please write D-SNP plans. This will affect us, which will affect the market and all this sorts of stuff. So I almost wonder if maybe there's probably not intentionality, but benefit to taking away less normal MA plan options for you to be a lot of these people can also go on D-SNP because they're not cutting as much D-SNP, C-SNP stuff, right?
Correct. Yeah.
It's more just the regular.
Yeah, more just like your main market PPOs, or like I said, some HMO POSs in some markets. So, and again, for example, here in Missouri, we actually only had one plan that was affected, and it was a plan in the Kansas City market. And in talking to our agents and looking at production reports and things like that, it was kind of a plan no one was really writing. I haven't looked up the enrollment data for that plan yet, but it was definitely not the market leading plan.
Yeah.
Now, in some markets, that's not the case. I know in some markets it was a market leading plan or a top 2 plan that is getting pulled. But again, just look at what that probably means for the future. So I think, looking at the D-SNP market, D-SNP and C-SNP are really valuable to carriers for a couple of reasons. One, risk adjustments. They have better data. Those are typically what, if you read a lot of our stuff from Deft Research, they'll more likely to be what they call polychronic, having more than one chronic condition that needs management and care. So those folks are great for risk adjustments. So when you're talking about plan revenue and getting money in the door to help cover those complex medical needs, D-SNP and C-SNPs where you can justify those risk adjustments, especially with the changes that HHS is making to the risk adjustment data validation and how they're going to be hiring these 2,000 new medical coders to help do audits and things like that.
Yeah.
those are plans where it makes it much more easy to validate that data, justify that compensation to the plan, and hopefully shrink that MLR a little bit. So obviously we have to stay above 85% medical loss ratio, but once you get into that 87, 88, 89, which a lot of plans are in right now, it gets very tough to make the ends meet in the middle.
Yeah, that makes sense. Well, I don't know. What else should we talk about as far as UHC sort of stuff goes? Do you have anything else?
I don't even think UHC specific. I think a lot of it is just looking at what's going on in this market, what's going to happen this fall, and what you can be doing right now today. And my gosh, there's so many things we could talk about.
Right.
So by all means, toss some
will.
questions in the chat.
Yeah.
We will. But, looking at your systems and processes. And I know that we say this all the time, but you need to be looking right now at what clients are on what plans, and you need to have an easy way to run a report in the event that you find out that one of those plans is going non-commissionable, or one of those plans becomes a service area reduction,
right,
or whatever it is. So if you don't have a system to manage your book of business, if you don't have a system to figure out which clients are on which plans without looking them up individually,
right,
you are going to lose business. We saw this last year. We had service area reductions in a lot of markets last year. Agents that were prepared were able to take those service area reductions and use them as an opportunity to grow their business faster than they have ever grown before.
Mm-hmm.
Agents who were not prepared spent their entire AEP just trying not to lose money.
Right. Yeah. And this AEP, we can probably expect you having to move a lot of people, like a lot of your med sup clients, to that to the MA side anyway. So already your AEP might look decently busy, and then you're adding these. You're going to have to take a look at who's on what plan and if they need to move, MA from MA. So it'll be an interesting year. Right now we're planning for the AEP boot camps that we're doing in our regional area here. And it'll be really interesting to see, just compared to last year, the sort of information that we're putting together, because a lot of it is similar. And, one thing that I kind of think about is we don't want to sound like, and we won't, because it's always been legitimate, but there were a few years where it was oh my gosh, the MA market, AEP is going to be awesome. The benefits are bopping, it's great. And then out of nowhere, it was oh, this is getting cut. This is getting cut. This is getting cut. Expect this. And now we're going into another year where it's hey, not only do you still have to deal with some of that complications with your MA clients, now you're bringing in your med sup people and throwing them over as well. So it'll be an interesting year. And I'm interested to see sort of when people will start to wake up to realize some of the stuff that they have to do for AEP.
Same panic, new disco.
Yeah. Period. Yeah, that's right.
No, yeah, it really is. I think that's the big thing that I want to get across to people, and we talk about this all the time. Regardless of how this AEP shakes out to be crazy, we know it's going to be another crazy AEP with huge growth potential. The advice just doesn't change. And I think some people are honestly a little disappointed. They think we'll have some new amazing solution, some magic solution to make their AEP super easy. But at the end of the day, the strategy doesn't change. The advice doesn't change. The tools don't change.
Right.
It's all about using what you have in front of you, whether that's Medicare Center, whether that's, whatever other enrollment platform you need. I'm about to sneeze and it's not going to be good.
Look at the light. Look at the light.
Okay, we're good.
Did that work?
So this is the joke in the office. If you've ever been to our office, you know that I sit kind of on one end of the building, and there's two doors between me and anyone else in this building. But if I sneeze, I constantly get messages on our little chat system from people on this end of the building that have heard me sneeze. So that's just my life now.
Yeah, sometimes it makes me jump. And we're not even near each other. Sometimes it makes me jump.
Yeah. Sadie's a good little bit of ways from my desk.
Cool. Well, we're definitely planning a lot of content, both on the senior marketing specialist side that's coming out, and some on the Medicare Cafe side as well, because you guys have been traveling. I mean, that's why Olivia hasn't been here. That's why you haven't been here. We have everybody all over the place having to speak on the stuff that's happening and what's to come. And so we have a lot of content that we're working on in order. We're kind of like in this awkward space where it's like we have the final rule stuff, we have some of this, but we have yet to see, we have yet to go to these rollouts and see like where some of these carriers' heads are like really at for AEP. So we're kind of like in this limbo stage right now. It'll be interesting as we get into this month, and then especially like July and August, what it'll look like. So
and I would even say, I know a lot of you work in more than one market. If you're in the ACA space, group space, whatever the case may be, don't expect those to be calm and quiet either. There's a lot going on in the ACA, a lot of things pending in the reconciliation bill that could affect how that ACA market shakes out this AEP. You all may remember the court case with, I believe it was Manhattan Life, that sued over the short-term medical and trying to get that bumped back to be available for up to 3 years instead of the current 3 months with a 1 month extension.
Mm-hmm.
And HHS actually filed an injunction saying, hey, let's put a stay on this because, we just got the new secretary installed. We want some time to pursue rulemaking on this.
Yeah.
So they asked for an injunction for 90 days to say, just kind of hit pause, let us take a look at everything because we want to pursue new rulemaking on this. So there's a big chance that before the end of this year, we're going to have new rulemaking bringing back those longer short-term medical plans. So if you're in the ACA space, especially if we end up with some subsidy reductions and a lot of folks rolling off of those, expect that to stay busy this year. I know we talk about it every year, but AEP just seems to get longer and longer. Like it just spills over into December, spills over into January, spills over. There used to be slow times of the year.
Yeah.
There really aren't anymore.
No, there's not.
So be prepared for that. Be prepared to still be meeting with clients in January in some cases, especially on the ACA side. Lot of opportunity this year.
We're also going to be seeing a lot of people leaving like this business, being like, no, I'm out of here. This is starting to get this is starting to get to be too much. So you also have to focus on like the prospects that you have around as well. So
if you're trying to buy a book of business, that's going to be a great way to grow. I will say you're kind of coming up on a deadline with that. Really, it's tough to start that process after August 1st. So if you're talking to folks that are going, I really don't want to take AHIP again.
Yeah.
You've got a short window to go ahead and get involved with them and find that opportunity to maybe take over their business, maybe look at a structured buyout that's contingent on retention, because this is definitely going to be a year where if you're taking over a business this close to AEP, retention is going to be the big key to what that business is actually valued at. Yeah. And again, understanding the mix of business, how much of that is actually paying the agent. Are they someone who wrote 400 non-commissionable WellCare plans last year, and they're including that in the value of their book? That there needs to be a little bit of honesty between you about that.
Yes.
Same thing with hiring. If you got over 500 clients and you don't have any help, you really need it. You need to be hiring someone to help you out with that. In my opinion, and I've gone on the record with this multiple times, it needs to be an admin, not a downline, because that's your role needs to be selling. Yeah, if you're at that stage in your business, you need to be out there talking to clients, selling products, setting appointments. Maybe your admin person can be helping you process paperwork, make calls to carriers, managing your calendar.
The money making
Exactly.
For sure. Cool. Well, guys, that's what we have for you today. We said it would be a little bit shorter today. But Chalen, thanks for being on. Next week, we're going to have, I believe, Olivia and Carrie.
I think so.
You?
Not me.
Okay, cool. I'm the one that makes the schedule, and I'm asking you. I believe Olivia and Carrie will be back on here. So like Chalen, they've kind of been traveling and whatnot. They'll have some good feedback on that. But glad that we could touch base with you guys again this week. But
absolutely.
Yeah, cool. Until next week, have fun.